started for the few that are on here. Is everybody good with that?
I think that's a good idea.
Okay, so, well, thank you for joining. This is being recorded, and we do have several requests to send out this recording, so we'll take care of that at the end of the call. But I'm Kim Michaud. I'm the owner of Clear Heart and Lung Imaging, and I have asked Dr. Tony DeFrance to join us and provide some education, mostly for our providers that send patients to our center. This was a request that I had from many providers was, now you've told my patient they have mild or moderate disease. What do I do with them? And so nobody's skill set is a better fit than Dr. DeFrance is. So Dr. DeFrance is a board certified cardiologist, interventional cardiologist, as well as being board certified in functional medicine, in lifestyle medicine. And so finding that combination is very unique. I always call him a unicorn of sorts in his industry. So I'm going to go ahead and hand it off to Dr. DeFrance. He can tell you a little bit more about himself.
Okay, great. Thanks, Kim. Can you all hear me? Okay.
Yeah.
Good, good. Okay. And you can see my slides?
Yeah.
All right. Well, thanks for joining tonight and taking some of your evening out to go, be on this webinar. I'm Dr. Tony DeFrance, and as Kim said, I'm originally an interventional cardiologist and have over the years migrated over more towards the prevention side of things. You know, as an interventional cardiologist, I was rushing in and putting stents in, and I did that for over a decade, almost 15 years, and was always feeling like I was a little bit late to the party. And so over the years, I kind of got more and more interested in how do we catch this disease earlier. Back around 2000, I saw the first cardiac CT images, CT angiography images, and I sort of instantly fell in love and thought this would be the future. Well, 25 years later, I think we're getting there. We're using it. We're realizing the potential. It's now being reimbursed and being incorporated into guidelines. So cardiac CT is something I'm really passionate about. I've read tens of thousands of studies, and I've trained over 3,000 physicians to level 2 and 3, which is the certification levels. And as Kim mentioned, I am interested in cardiometabolic illness and the kind of root causes of disease. And as such, I've created a little enterprise called MedMentor, and I have two of our team members on the phone if there's any questions, Jane Fenton and Anka Johnson. So they can, Jane, did you want to introduce yourself quickly, or and Anka?
Yeah, hi everybody. I've been working with Tony for a few years here at MedMentor. I'm a certified health coach, soon to be functional medicine coach, executive coach, and yeah, we're really looking forward to tonight's presentation, and glad you could join us.
And my name is Anka Johnson. I am a board certified functional medicine nutritionist as well as a health and life coach. I've been doing that since 2003 in various capacities, and I've been with MedMentor for about a year and a half now.
Great, great. And we'll tell you a little bit, but at the very end about MedMentor, this is really a talk about sort of the evolving future of coronary disease. You can see the title there, but a lot of the theme is moving from risk factor-based medicine to disease-based, more precision treatment. So what you'll walk away from this talk, hopefully, if I do my job correctly, is a practical way to interpret plaque findings, a framework for matching treatment intensity to the burden of disease. So when we see more disease on a cardiac CT angiogram, the treatment is different. And then a strategy for addressing some of the upstream cardiometabolic drivers, and I'll tell you what that means more. And there's really 4 ideas here. First, the limits of risk assessment and why risk factors and ischemia testing alone, in my opinion, aren't enough. And second is plaque phenotyping, how CT angiography plus the quantitative plaque analysis. So not only doing the angiograms that Kim Center does so well, but also using some of these more advanced plaque quantitation companies like Clearly or some of the other plaque companies. How that really lets us do true precision prevention. And then third, a staging framework that maps disease burden directly to treatment intensity, sort of the way oncology has done for decades, right? They match their treatment to disease burden and stages. And lastly, fourth, the upstream metabolic drivers that I mentioned. What's actually causing this disease, and how do we manage it, optimally? So if there's one thing, hopefully you take home from all of this, I'll just say it up front: stage the disease, then match the intensity of treatment to the stage of disease. And I'm going to show you how to stage coronary disease because that's a new concept. And, we're all pretty aware of this. We're kind of still losing the fight with coronary disease. We've done a lot. We've had great advances in PCI, stenting, et cetera, and drug therapy. But we still have about 1 million annual cardiovascular deaths. We have 400,000 to 500,000 sudden cardiac deaths. Most of them don't have prior diagnosis of coronary artery disease. And about half of all patients present with myocardial infarction as their first known coronary disease. That's scary, right? We're missing it until they're in the hopefully make it to the emergency room if they're not one of the sudden deaths. And then that's where people like what I used to do is come rushing in and try and open up the arteries. And I think we're really the bottom thing. We're better at treating risk factors and preventing the disease. And it's the gap between what we measure and what actually kills patients. I don't think it's ever been more apparent now that we have some of these tools. So, I'm not kind of trying to discredit traditional cardiovascular risk factors. They've served as the foundation of preventive cardiology for decades. But I think mounting evidence reveals critical gaps that we can't ignore at the individual patient level, right? Most of these risk factors are derived from large population-based studies, but when you're sitting across looking at an individual, a lot of times those that large risk models and risk factor evaluation doesn't really treat the patient appropriately. So they've got us a long way, but they're surrogates and they're showing their limits. I mentioned already half of heart attacks happen in people with no previous symptoms and also with a normal cholesterol. So that's really one of our most widely used surrogates is LDL levels, cholesterol, and in many cases that's failing us. And probably you've used the ASCVD risk calculator to try and estimate risk in people, but the area under the curve is only about 0.7 for heart events, so it's modestly better than a coin flip. And it's kind of miscalibrated in certain subgroups like women and younger adults and racial and ethnic minorities, et cetera, people that we need to catch. And lastly, I'm a big proponent of biomarkers, some of the new ones, ApoB, Lp(a), inflammatory markers, but I think they're just early, and those so far haven't really fixed our problem of all the disease that I talked about in the last slide. So I think you can keep refining the surrogates, but a surrogate of disease isn't the disease itself, which is one of the main points I'm making here. And so new guidelines just came out for the management of blood cholesterol, dyslipidemia, ACC guidelines, et cetera. It's one of these massive documents of 100 pages. And if you go, read to the very back, it kind of summarizes things. And a lot of the good stuff gets buried in the back. But I think, that it's progress. And so there's a couple changes. I'll just summarize quickly. The prevent model. So they came up with a prevent model, the AHA did, that replaces the pooled cohort equations with a better calibrated risks tool. Now, why is it better? Kind of incorporates more factors in it, and also it gives a 10-year risk and a 30-year risk, right? Because coronary disease has this long timeline long course. So the prevent model is an improvement over what we were doing, but it's still, it's a probability, and it's better than previous, but it's still, based on populations and not on individuals. And so the other thing is, that they've done in these new guidelines is they're using imaging to reclassify things. And they didn't choose cardiac CT angiography, but primarily they focus on coronary calcium scoring. And that's become a class 1 recommendation to help in the cases where the risk score, the prevent model, leaves it uncertain. So, those kind of intermediate risk patients, adults, whether it's the 10-year or the 30-year risk, the question is still what to do with them. And if we look at about 40% of the intermediate risk adults have a calcium score of 0, and about 25% have a high score over 100 with very high event rates that make them look like a high risk patient. So it's the same bucket. It's this intermediate risk group in terms of the models, but you really need the imaging to push them one way or the other. The biology is different in the patients, so you got to see the disease. So I'm going to emphasize that point throughout this talk. What about subclinical atherosclerosis? I think there's now a dedicated section to that with thresholds. They recommend treating any calcium score above 0. And if there's a 0 calcium score, you can defer. But, unfortunately, calcium score is only showing calcium in the arteries, which is kind of the healed component almost of atherosclerosis. It's not showing all the more relevant non-calcified plaque, the low density non-calcified plaque that is correlated with very high event rates and problems. So I think they included calcium score mainly because it's been around for quite a bit longer and there's more data, and you know how these guidelines always need tons and tons of data before they'll incorporate. But I think we're moving towards recommending cardiac CT. The data, these guidelines just haven't caught up with what's happening in the field. And then the last thing is the LDL targets. We've been chasing percent reductions, and now they're back to numeric targets. And we can talk a little bit more about that as we go. So, there's the prevention, but this is what's happening in practice mostly, right? This is the famous Netter diagram of a middle-aged white male who's exerting and clutching his chest there. And then if he's not having an acute MI and taken to the cath lab, they're typically have some sort of functional testing, stress testing with images typically. And if they have ischemia on that test, then they end up in the cath lab, the image on the right. And if we see a narrowing there, then they're going to have I can tell you as an interventionist, they're going to go in and stent this. So it's this kind of reflex. If the patient has symptoms, they're at risk of a bad event. And if I relieve those symptoms, I reduce their risk. Turns out that's not true. I mean, that's what fills up our cath labs. But, if you look at this next slide here, you're probably familiar with these massive studies that have been done over the last 25 years, the COURAGE trial, FAME, ischemia. And really, they all show, although you may get benefit in symptoms, there's no survival benefit for the vast majority of the PCIs we do. And again, remember, I'm not talking about acute coronary syndromes, MI, PCI in those cases. I'm talking about the patients who are having more stable chest pain. So basically, every landmark trial in the last 25 years, same finding: treating ischemia and stenosis resolves symptoms and improves quality of life somewhat, but has no statistically significant benefit or effect on prevention of myocardial infarction or major adverse cardiac events. So pretty interesting, right? We've been looking for these stenotic lesions, waiting for symptoms, and again, not working. And here, I think this is one of the most important slides and something that many providers to this day don't realize. And the finding is that 2/3 of the plaques that cause acute myocardial infarctions don't have what we consider obstructive stenosis. They have less than 50% narrowing. And honestly, it may be up to 3 out of 4, 75%. So let me walk you through the slide. On the middle figure here, that's invasive cath. And what it's showing is After someone had an MI, they went in and looked at the culprit lesion, and almost 70% of the culprit lesions were less than 50% stenosis. Only 15% were from more severe stenosis. Things that we're typically looking for was stress tests or treating in the lab. If you look over to the image on the right, that's the cardiac CT. On a per patient basis and a culprit lesion basis, let's look at the culprit lesion. Again, same thing. 75% of the plaques that cause myocardial infarctions are less than 50%. So all the testing we do, the waiting for symptoms, the stress testing, even the advanced stress testing, the stress PET, the stress nuclear, the stress echoes, are not going to detect these less than 50% narrowings typically. And I've seen that many times. We go in and we treat the severe looking stenosis, the 80, 90%, and they're back in 3 months with an MI and a whole different distribution. Not a great thing. So I think, this is a really important finding, and it's really the plaque biology in those 50%, the active high-risk plaques that we want to identify. And I'm going to make the case that cardiac CT is one of the best ways to do that. We can see certain plaques that have high-risk characteristics. So where does that leave us? What my points here, I'm just summarizing. Risk factors alone miss too many patients, right? We talked about some of those things, those statistics. 50% of MIs, that's their first ever presentation of CAD. Ischemia and stenosis are incomplete endpoints. I showed you the trials and how functional testing and revascularization do not allow us to prevent events. And it's really vulnerable plaque biology that we need to be looking for. And we need to see, characterize, and stage the actual disease. And it's my strong opinion, the only path to true precision prevention is direct visualization and quantification of coronary atherosclerosis before it ruptures, before they have symptoms. So I know that's a little bit maybe controversial, but I think imaging is going to become really the paradigm shift, imaging the arteries, just like stents. I trained and did my fellowship when we moved from just doing balloon angioplasty to stents. That was a big paradigm shift. And I think this is the next one, seeing the disease on high quality scanners like what Kim has at Clear Heart and Lung. And, I think here's an interesting question. In oncology, we built imaging-based screening pathways, right? They find disease, hopefully before they have symptoms, mammography, colonoscopy, low-dose lung CT. We image the organ, look for disease directly. But in cardiology, which has the #1 cause of death still in cardiovascular disease, we've relied on surrogates and signs, risk factors, symptoms, and stress tests. So let me go back. Sorry, this comes in slowly here. Oh, there, it's just the slow. So it's just showing how, imaging for cancer, but in heart care, we're using, surrogates like cholesterol, waiting till people have symptoms, and looking at sequela like stress testing. So I think now with platforms like cardiac CT, with clearly plaque imaging, we have the tools to detect and quantify the disease now. So it's time to start kind of approaching this disease differently. And so what we can do now is that we can now stage coronary disease, right? Coronaries, had no staging system up until recently. So every major cancer has had staging for decades and defines the prognosis and the treatment based on stage. But and you don't treat the stage 1 and stage 3 the same usually, right? And I think with quantitative coronary angiography, we can now do the staging and make a difference here. And those just kind of emphasize that. So I think that really that calcium scoring, just jumping back here, calcium scoring, talking about staging, was the first step in this process of trying to figure out how to stage disease. And I think there's some really good things about it. You can read them here. It's a strong independent predictor of major adverse cardiac events, low cost, guideline endorsed, especially in the new guidelines I mentioned. And it can be a motivational tools, but it's missing the non-calcified plaque, which is the biologically active and rupture prone component. I'm sure Kim can relate stories of zero calcium scores at the center and finding pretty significant and severe high-risk plaques that had a zero calcium score. So calcium score can't do the plaque composition, and it really can't do the stenosis or ischemia measurements that CT coronary angiogram can. And this is an important statistic. Nearly 1 in 4 MI patients have a coronary calcium score of 0. So I'm not saying this is the wrong test. I'm saying calcium scoring is good, and cardiac CT in many instances is better for the subclinical atherosclerosis detection and characterization. And really, what we now have, again, speaking, I'm going to get back to the staging thing in a minute that I was talking about. But we have this tool now that we can evaluate plaque non-invasively at scale with very low radiation dose, low contrast doses, and amazing plaque visualization. I mean, the criticism in the past was, oh, the radiation dose is too high. But, with the newer generations of machines, we can do this for, 1.5 millisieverts, which is tiny doses of radiation. For example, a stress nuclear study is 12 to 14 millisieverts. So, very small doses for what you get here. And this is just looking at the left anterior descending coronary artery kind of longitudinally stretched out. Then this is from one of the plaque analysis programs. It uses AI to outline the lumen of the artery, and then the outer wall is outlined in yellow, and everything in between is plaque. And so then we can go in and look at what type of plaque. We can measure the density of it. So one slice there, the top slice that might have the low density. This is the really nasty, high risk of event stuff with a necrotic core plaque that correlates with. There might be fibrofatty plaque in there, fibrous plaque, lightly calcified, more heavily calcified, or very heavily calcified plaque, all in the same artery, right? We call those really heavily ones 1K plaque. And the risk, it really changes. And it goes, as you have that dark stuff, dark is bad, right? The dark plaques are bad. And as you move towards more calcified plaque, those tend to have lower risks. So one of the things about measuring serial calcium scores, I used to do this too. I'd be treating aggressively, and then the calcium score would be going up, and I'd be like, oh no, I'm not doing it right. But that's actually, we're finding out that's what you want to have happen, right? On these, and I'll talk about it, transforming the plaques. What you want to do is, if you find a bunch of this low density or fibrofatty plaque, if you treat it aggressively, you want to see the calcium going up and the necrotic core or the fibrofatty going down. And that's the kind of stuff you can measure. So again, dark plaques are dangerous, strongest predictor of heart attack risk. And you can see the rest. Bright plaques are stable. We can transform plaques over time, and with all this prevent heart attacks. And so I'm just listing here. I'm not going to spend much time on this busy slide, but what we can see with the cardiac CT plus the quantitative plaque analysis, we can see the total disease burden. You get a score there with how much disease is in all the coronary arteries. You can see the composition of the disease like I just showed. We can see high-risk features. There's certain things in plaque that make them higher risk. I've listed them there, the low attenuation, the dark stuff. If it's positive remodeling, so the artery is bulging outward, and there's a couple others. We can see where the disease is it proximal or distal? We can see how much and very precisely quantitate the amount of stenosis. And we have AI algorithms that can figure out the likelihood of ischemia in that vessel. And then the last thing, we can track the disease over time and the treatment. Is the treatment working? Because as you all know, statins are good drugs, but you get a 20 to 25% relative risk reduction. So what does that mean? That means 75 to 80% of patients you put on statins aren't getting a risk reduction. And we can measure that on cardiac CT and see if they're statin responders or not. So I think that's really important. So getting back to the concept I kind of told you about the staging and then kind of, went into some other things. But now, that you can see using this cardiac CT and plaque quantitation, we can stage disease. And this is from a really important study that Jim Min published several years ago, now 4 years ago, showing there's specific cut points we can use for plaque. So there's 0. And these stand for TPV, is total plaque volume in cubic millimeters. And then this is percent atheroma volume. These are 2 ways. So that takes into account how much of the lumen has plaque in it. I tend to use this TPV number. So 0 is no plaque. Then the stage 1 is 0 to 250. Stage 2 is 250 to 750. And stage 3 is plaque everywhere. And you can see these images that with all the plaque colored in, with the blue being calcium, yellow being non-calcified. So these people with all this plaque here are at really high risk. And I'll show you kind of the results of kind of breaking it up like this. Not only is it, good cut points, but it also is important in prognosis, we found. So this is looking over 10 years, stage 0 plaque, have almost no events. So this is survival from major adverse cardiac events and follow up to 10 years. So when there's a 0 score on, 0 cubic millimeters of plaque on a cardiac CT, with Clearly or with another one of the vendors, no events almost. When they have stage 1, there's about a 10% event over that 10 years. Stage 2, 20%. And look at these stage 3 patients, really high event rate, 50% event, major adverse cardiac events. So these stages not only, are nice clean cut points, but they, directly correlate with prognosis. And I think it's the burden of the plaque burden, not the calcium score, not the stenosis. It's really the plaque burden, which is the strongest independent predictor of future events. So this is better than the AES-CVD or pooled cohort risk scores that we've talked about, the PREVENT score, the Agatston calcium scores, and even better than stenosis degree. So big change in looking at prognosis, I think, with these quantitative plaque programs. And so, but what do you do with that, right? I told you at the beginning of this, I talk about staging the disease and then treatment. And this is a bunch of preventive cardiologists from the ACC got together to try and figure that exact thing out. So you have your stages on the left-hand side, and then they broke it up into diabetics on the bottom and non-diabetes on the top. And they have different treatment recommendations. And so stage 1, they're pretty aggressive here. They're using statins, PCSK9 inhibitors, or other, lipid lowering medications at stage 1. And if they have diabetes, they're using some of the GLP, et cetera. And then if they have stage 2, they're adding in thrombotic treatment. And stage 3, they're going, kind of full court press anti-inflammatory. And actually, they found, interesting relative risk reductions with influenza and COVID boosters as well. So there's clear recommendations at each of the stages, how you would treat them differently and treat them aggressively. And actually, we're Clearly has a huge trial going on now. They're enrolling 10,000 patients, and Kim and Clear Heart and Lung is going to be one of the mobile scanners that goes around and scans these patients. We're looking in asymptomatic patients with prediabetes, diabetes, or metabolic syndrome. We're scanning them, and based on what stage they're in, we're treating them very aggressively. And then we're going to rescan them, see the progression, and then we're looking at events. So by 2028, I think this study will be finished. What we suspect is we're going to see massive reductions in risk and mortality with aggressive treatment of stage 2 and stage 1, 2, and especially stage 3 disease. But that's stay tuned for that, because that will, I think a lot of the payers will then need to pay for that if we can prove that we reduce mortality. So just kind of summarizing that, having this precision prevention toolkit. And we have 4 axes that we can work on: the lipoprotein axis, right, with statins, ezetimibe, the Repatha or PCSK9 inhibitors, and inclisiran, and others, to get to an LDL target that's very low. We're actually driving in those stage 3 patients in the Transform trial. We're driving the LDL-C down below 30. So very aggressive treatment, as I'm sure you guys are aware. Getting a less than 30 is not all that easy, and we usually need multiple agents. But that's the lipoprotein axis. Then there's the cardiometabolic axis, the GLP-1s, the SGLT2 inhibitors, et cetera. The inflammatory axis. So, there's data on colchicine. I know some people kind of question it, but I think some of the data is decent. Also, visceral fat reduction, right, to reduce inflammation, and a lot of lifestyle things. And then the thrombotic axis again. So it's not just like, oh, well, just put everyone on a statin, on a statin. That's what I used to hear. Why don't you just put statin in the water, right? But I think now we have these different axes we can attack this disease from. And again, it might look like, I'm just emphasizing this point: stage 0 plaque lifestyle optimization, stage 1 moderate intensity statin, plus probably some of the metabolic targets, and stage 2 and stage 3 ramping up the level of aggression of treatment. So really, the staging framework is only as useful as its ability to directly drive your clinical decisions. And I think each stage, maps to its distinct and escalating treatment intensity. And, I think this is great. And I'm a strong believer in pharmacological treatment for these, people with advanced disease. But, I'm going to complicate the story I'm telling. Everything I just showed you is pharmacology, super powerful, evidence-based, life-saving. But I think, what are these drugs doing? They're managing the downstream consequences. Statins lower LDL, right? And GLP-1s address metabolic risks, et cetera. But none of them really address the upstream question, which is what's driving the atherosclerosis in the first place. And that's what I got really interested in and started studying and, digging into functional medicine, lifestyle medicine, things, looking for root causes and how to uncover them. And why do some patients on maximal therapy still show plaque progression on serial imaging? I think the answer is upstream if we look at the drivers in the metabolic environment that started the process. Excuse me. And here's, I just put this figure together, what I call the cardiometabolic cascade and here's really the underlying drivers, right, of coronary artery disease and most of our other chronic illnesses. These upstream drivers: ultra-processed foods, poor sleep, chronic stress loads, kind of losing your muscle mass, sarcopenia, and cardiovascular, conditioning, gut microbiome, toxins, all those things start causing the metabolic dysfunction decades before we see manifestation of coronary disease, right? We get energy overload at the cellular level, mitochondrial stress, insulin resistance, this loss of metabolic flexibility, the ability to burn fat and sugar and kind of flip back and forth. And then, over time, you start seeing the diseases associated with these metabolic dysfunctions: visceral fat, ectopic fat accumulation in the liver, muscle, causing more insulin resistance, chronic inflammation, all the ApoB particle increases, endothelial dysfunction, and finally, in that fourth bar, the clinical expressions, right? What we're talking about here is atherosclerosis, but as you all know, diabetes, fatty liver, hypertension, the dementias, et cetera. And I think one of the things that I'll talk to you about at the very end here is, I'm kind of interested in working with, you met Jane and Anka at the beginning, is kind of how do we intervene in this and complement the pharmacology? Again, I'm not an med doc or anything. I just think that we should be doing a lot of these things to get at the root causes of the disease once we know it's there with imaging. Right. And this just summarized, I'm not going to spend much time here, but, some of the major upstream drivers, and some people have more of this than others. Some people will be very insulin resistant. Some people have a lot of visceral adiposity, right? The fat tissue around the gut. Some people are more inflammatory and have a lot of inflammation. Some people are just very metabolically inflexible, like I mentioned. Some people have lost a lot of their muscle mass, which is really important for metabolizing sugar and insulin resistance. So, yeah, I mean, I think I've made the point there that I think getting at the upstream drivers of all this is essential. Um, and this used to be me, right? It's like I was so busy and seeing, 20, 30 patients a day running the cath lab, and I knew they should do something different. They needed to change their lifestyle. Then it was like fat was the enemy. I think we've evolved a little bit, but eat less fat, exercise more, right? But I never had time to go into anything more than that, and we didn't have any nutritionists or anyone working. I don't think there even was such a thing as a health coach back then. But so how do you do this? How do we help them implement these lifestyle changes? What food, biomarkers, which interventions, for how long, with what support? And I think it's really hard. Now I know some of you on the call, I can't see exactly who joined, but some who are going to join are actually doing this, and whether it's a concierge practice or more focused on this side. So I think some docs are moving much more in this direction, which is root cause medicine. And I'm just going to give a couple slides on this concept of med mentor, because I've sort of moved again from interventions to wanting to help people. And this came out of, doing all these cardiac CT studies. And then I'd either have physicians coming to me and saying, well, what do I do with this? Like all these like numbers, and this is, how do I treat this? Do I just put them on a statin? And then the patients were coming and saying, what does this mean? My doctor isn't sure what to do with me. So, I started thinking about this and kind of working on it, and how do we put something in place? And so one of the things I do is some patients want, hopefully you guys are talking to them and explaining what it means, but some patients want an expert in cardiac CT. So I'll go over their scan with them and kind of teach them what the plaque is, what's going on. The type of patient that wants that sort of detail. So, and so I'll do some of that. And I kind of just obviously you guys are doing lots of this, but what's difficult in traditional practice, and this how to do it is really hard to do in practice, at least in my experience. And what we're trying to do is not in any way compete with docs or change medicines. Let me just make that very clear. I am not saying, oh, you shouldn't be on a statin. That would be crazy, right? I'm trying to really help them focus on the lifestyle changes they can make to complement the treatment regimens that they're getting. So how do you, it's the in between the visits that are the tough part, right? How do you give them structured education and accountability, and complement what's happening in practice? So that's what we were looking to do. And so we've come up with a couple things like a 5-week cardiometabolic intervention program. So if we find certain patients that have plaque or, pre-diabetes, diabetes, metabolic syndrome, other things, and want more help, we have a series of micro-learning videos. You met our health coach, Jane, group accountability, evidence-based nutrition. So there's an online platform. They can ask questions, chat groups, and we take them through over these 5 weeks. There's a pre-week here too, but kind of teach them like what is going on and what's driving this. And we've tried to price this so it's affordable, less than $600, so that people, insurance isn't currently paying for this, but we're trying to help in this realm. And as you know, like some this is not for everyone, right? Some people right after they get their plaque scores are most motivated. I used to see this all the time. Right after their myocardial infarction, they were motivated for a couple months, and I had their attention, and then they drift off. So those are some of the things, elevated coronary calcium score or CTA, that may make them benefit from a program like this. And then, what we're trying to do also is help if they need longer term, if this 5-week program isn't enough and they want ongoing help with lifestyle change and management, we offer kind of a maintenance program, et cetera. So I'm not really trying to sell. I mean, I'm not a salesman. I'm not force this on you guys in any way. I'm just trying to come up with a solution to what I think is a massive problem that, you know, if not in your practice is already being addressed, needs to be addressed. I get calls every day from docs like, what do I do with this plaque score, et cetera. Now, last couple slides, and then I'd love to take some questions if you guys have, and I know I've gone through a lot of stuff, but one of the exciting things for me in cardiac CT is I think for the first time in prevention, we can see if we're actually preventing disease and see if we're helping them. So we can do these serial cardiac CTs now that the radiation dose is low, and if they have very advanced disease, like let's say stage 2 or 3, we might even consider repeating another cardiac CT in a year to see if the treatment we have them on is stabilizing the disease, transforming the plaque, et cetera. Again, we can look at the composition change in the plaque, which is really important. I told you that we want to see the non-calcified decreasing and the calcium increasing. That's typically what happens. It's not like the non-calcified just vanishes. It sort of tends to calcify as the healing process. And so we can see this verified therapeutic response. And then it's motivating for patients. And if they're not benefiting, then, we need to get more aggressive. I have some great cases of, we put them on statin drugs for a year and they come back and they're way worse. They have more non-calcified plaque. And so then we added Repatha and they come back again. And you can see that, or another drug that we added changed the course of the disease. And this is just a really quick case. This is from the Clearly plaque analysis. It straightens out this vessel. And what you're seeing here is a straightened vessel view, but this is the plaque. There's the lumen boundary, and then there's the outer vessel wall. So this is positive remodeled plaque. It's bulging outwards. And these colors represent the red. Obviously, red is bad. That's the low density plaque. So this is a very biologically active, nasty, high-risk plaque. But is there a tight stenosis? No. Right? You can see the lumen there, I would say 40, maybe 50%, but this is one of those high-risk plaques that is at very high risk of rupture. So this patient was treated, I think, with high-dose statins and other medications, and 18-month follow-up. You can visually see here that there's still a little red, but we've really reduced it. You see there's less remodeling, and the plaque's transforming. I don't see any blue yet, but if you look at the table over here, what we see is the plaque volume has, let me just make sure I see. So the plaque volume has gone, sorry, low density. Okay, so this was the former study, and this is the more recent study on the right. So the plaque volume's gone down. Now, we don't often see too much of that. Often it stays the same. But in this particular case, you see the total plaque volume go down. This is the more important one. The non-calcified plaque volume has dropped dramatically. About, I put the numbers down here below. And the really important one, the low density non-calcified, the really nasty stuff, has dropped 52% from 67 down in half. So this is the kind of thing we want to see, right? And you can't really see it, but the calcium is increasing. It just may be out of the field of view here. So this is what we want to see. We're measuring the progress of this disease with aggressive treatment. And so I'll close where I kind of started. The future of prevention, I think, is moving beyond estimating risk towards staging and treating disease by seeing it and longitudinally over time. And the three principles I've kind of tried to emphasize: stage the disease, not the risk. See the plaque and quantify it. I think that's important. The second is treat the plaque biology, not the stenosis alone. Most events come from biologically active plaque long before it obstructs. And 3, combine the 4 elements, kind of imaging, pharmacology, structured lifestyle, and kind of serial follow-up and verification if needed in this patient. So I think we've spent a generation getting good at predicting events, but this is finally how we start preventing them, right? We stop treating the probability and start treating the patients with precision medicine. So I know that was a lot, so I'm going to stop there and let me shut down my slides. Happy to take questions or share slides, etc. I can't see anyone. Did I overwhelm the heck out of everyone? I've been known to do that. But
You are still sharing the screen, Tony.
oh, am I? Okay, let's
Yeah,
see. Oh, there, stop share.
there we go.
There.
I know
So,
both of them, there's a couple on yet and they're still on mute, so I'm not sure if either of them have any questions or not, but you'll have to unmute if you have any questions.
yeah. And if no questions, that just means I covered everything imaginable anyway, right?
Mhm.
Yeah, an exciting paradigm. I mean, we can see the disease, figure out, the risks, and then get in there with our pharmacology and get in there with there's really good data on lifestyle management and all the drivers of disease now. This is not airy-fairy medicine. That's what people used to call this kind of stuff, right? Yeah, yeah. But I mean, the data on diet, diet's a hard one because it's just it's like a war zone. You go in and like the keto diet, and this is fighting with this one and chaos. But I don't know, Anka, how you deal with all that. But I think the
There's a
diet,
magic wand.
yeah, the science of lifestyle change, of kind of chronic stress, of sleep. We're realizing sleep deprivation. I mean, even a couple nights abnormal sleep, you can measure insulin resistance go up. I mean, there's all these factors that really
And stress.
are
Yeah.
contributing to atherosclerosis, this decade-long disease that finally, it's a lot of people think, oh, I had a heart attack, and they think, okay, that just happened and now it's done. But it was like 2 decades, 3 decades going on in their body until that event, and then someone like me comes rushing in, opens the arteries, throws in a stent, and they think, oh, cured. But that's not how this works, right? As you guys on the call know. So I've talked enough.
So
Well, from anyone
we are
want to ask a
recording this.
question?
Yeah,
What?
any questions? I don't know from Tim or Stephen. If not, we have recorded this and we'll be sending this out to all the people that couldn't make the call tonight.
Yeah. Kim, do you have anything? I mean, one good thing. I know a lot about cardiac CT. I actually owned four centers in my previous life at some point way back when. So I know a lot about cardiac CT, the machines, equipment, what Kim has at the site. What is it? What do they call it? A 520 slice? I don't even, the Araneta, what is it?
60,
640
equivalent
or
to a
something.
560, yeah.
Basically, it snaps the whole heart in a single, a fraction of a rotation. So in a couple hundred milliseconds, it's got the entire image. We can see all the arteries at really low radiation dose. It's phenomenal. The images that I get to look at from your site are stunning. It's kind of mind-boggling that where this technology, because I started when there was we were doing it on 4 slice machines. People have to hold their breath like 40 seconds, forget it. I mean, and then we're all excited because we got a 16 slice, right? And then, and then,
Mhm.
now you got boom, in one single snap, there's the whole coronary tree. So,
Yeah, and I think you hit on a major key, which is, the quality of the equipment is really what drives the accuracy of, the reports that you generate, that the patients take with them. Because I hear plenty of cardiologists saying, I try to order CCTA, but I don't get good image quality. Well, they don't have the equipment to do it, so they kind of give up on the modality. So I think uh, making sure
yeah.
that you're, on good equipment is what's really going to ensure the accuracy, not only of your read, but also of the plaque analysis, right? I mean, from an AI perspective, quality of data going in is quality coming out. So,
Yeah. The way I say it is garbage in, garbage out. So, like if crappy studies, yeah, I don't care how good your AI is, you're going to struggle. And, it's not only that, like you said, the quality of the equipment is crucial, but the quality of the imaging center clinical protocols and the referring docs. I mean, because almost everyone, I think needs some oral beta blocker before they get there. We need nice, slow, steady heart rate, right? Unless there's a really serious contraindication, they should have some oral beta blocker. And then when they come to the center, if they need it, you can give them little bits of IV beta blocker to complement that. But I mean, good centers know how, like yours, Kim, know how to do that and do it well. And so you get just reproducibly great images, so that I can read them and the AI can quantitate the plaque accurately, et cetera. Everyone
Thank
had
you,
enough
Dr.
for one night.
DeFrance. No, I
All right.
think that was amazing. And I know
Yeah.
there will be plenty of folks watching this later on. And so I really appreciate the time and effort that you put into not just tonight, but in preparation for this. I think it's going to be used over and over again by many of our providers.
Great. My pleasure.
Okay.
Take care,
Okay.
everyone.
Thanks, everybody.
Thank
Thank
you.
you.
Thank
Bye-bye.
you.